Today we will start with our first talk, that is the clinical vignettes in neurology. The talk is to be delivered by Dr. Mitul Kasundra. I would like to welcome him. This is his first talk in our clinical meet. So we all request Dr. Mitul Kasundra.
So good evening to all. First of all, thanks to APR, Dr. Tejas sir, Dr. Ankur for giving me opportunity for providing the platform. So we are discussing the case-based discussion. So first case, a 22-year-old male patient developed the fever for 2 days. Outside he is consulted and treated, and at that time laboratory investigation only the CBC was done, and that was suggestive of the 6,300 WBC count, and that it was lymphocytic, and illness was improved within 1 to 2 days. 6 days after the onset, the patient developed the stretching sensation in both lower extremities, followed by weakness in both lower limb. So initially in form of the difficulty in standing from squatting, followed by difficulty in walking, and progress is up to that he unable to walk and stand over the 3 days. So weakness of both lower limb over the 3 days, truncal weakness in form of the difficulty in turning in bed, difficulty in swallowing, change in speech, and urinary retention and constipation, which were exacerbated over the next 2 days. So based on history, what will be the diagnosis? Yeah. So now come to the examination part. Patient was alert, oriented. Neurological examination suggestive of the right facial nerve palsy, bulbar palsy, hypotonia of all four limbs. Lower limb are more involved than upper limb. Weakness in all four limbs in form of power in both upper limb is 4/5 and lower limb is 1/5. DTR in bilateral upper limbs are +1 and lower limb are the absent. Truncal weakness. Diaphragmatic weakness is present in form of single count is only 11. Weak neck muscles and sensory loss below the entire area below the T2 level. And voiding dysfunction that require the urethral catheterization along with constipation. He requires the enema. So now based on the history and examination, so neurologically, first of all, after assessing the history, first of all, we decide the level of localization. So now, based on this history and examination, anyone? First is GBS. So which are the odd points against the GBS in this case? Yeah. So yes, both are the factors that against the GBS. So localization and choice of investigation. So patient has acute onset sensory involvement with sensory, followed by motor system involvement in form of the quadriparesis. Lower limb are more involved, and autonomic dysfunction in form of the bowel and bladder involvement over the 3 days. And after that is the post-febrile illness. So now the localization based on the examination. So which are the structures are the affected? So cranial nerve involvement, so most likely brainstem, motor system, pyramidal tract, that up to the subcortical to the up to the spinal cord, and the sensory involvement with sensory level. So most likely is the spinal cord is also involved. So acute onset, brain plus spinal cord, post-febrile in young male patients. So which are the possibilities after this discussion, and which investigations we will advise in this case? First, particularly the imaging. So first of all, we have done the MRI brain. So which was suggestive of the T2 flare hyperintensity in the bilateral subcortical frontal parietal occipital white matter, which was left was more affected than the right side. This is the involvement of the pons and cerebellar peduncle. So this is the cervical spinal involvement of the multiple segment, that is a longitudinally extensive, more than 3 segment of the vertebral involvement in the spinal cord is there, along with dorsal spinal cord, and now also the conus part is also affected, that is the end of the spinal cord. So based on this finding, clinical features, so which are the most likely diagnosis? Yeah. So patient has the acute onset disseminated encephalomyelitis, brain plus spinal cord. So laboratory analysis was done, normal CBC, RFT, LFT, negative viral markers. CSF was done. Cells are 110, 90% lymphocytics. Protein is also 80 and sugar is 82. So protein is elevated, lymphocytic pleocytosis is there. CSF PCR for HSV is negative. So now the etiology. So based on CSF examination and MRI pictures, anyone? Infective, inflammatory, metabolic. So if we see the young onset, post-febrile, patient has the brain as well as spinal involvement with CSF suggestive of the more likely the pleocytosis, lymphocytic pleocytosis. So we have thought the first possibility is the inflammatory or autoimmune myelopathy or disseminated encephalomyelopathy. So ANA was negative. So we have sent the anti-MOG antibody, serum anti-MOG antibody, that was the positive, and anti-aquaforin antibody, that was for the NMO, is the negative. So diagnosis was MOGAD, that is the myelin oligodendrogliosis associated disease, and that was presented as the ADEM. So treatment, we have started on the plasmapheresis along with IV MPS for 5 consecutive days. With 5 cycles of the plasmapheresis, we have instituted on the alternative days. Early rehabilitation was implemented. So after the 5 cycle of plasmapheresis, significant improvement was found in the both lower limb weakness. Power was improved to 3/5, respiratory muscle improvement, and as well as the swallowing improvement. And also the urethral catheter was removed after 21 days after the onset of symptoms. So after IV MPS initiation, oral prednisolone was started along with the azathioprine. So after the 6 weeks of the symptom, the power was, and right lower limb also improved to 4+, left lower limb is 4/5, upper limb is also 4+5, and patient can walk without the support. And follow-up MRI after the 1 month after IV MPS showed also the reduction in all CNS lesion. So this was the gate after the 6 weeks. So I am coming to the case 2. Then we will discuss the both cases simultaneously. 27-year-old female patient presented with complaint of the blurring of vision in right eye, acute onset with headache for 3 days, followed by the blurring of vision in left eye for the 1 day. No history of double vision or fever or difficulty in chewing or swallowing. Past history, before 2 months ago, she had the blurring of vision in right eye for 2 days, and she had consulted to ophthalmologist and treatment taken. Her vision was improved within the 3 days, but documents are not available. So on examination, visual acuity in left eye is 6/24, right eye is 6/36, color vision impaired in both eyes. Fundus on left eye, optic disc edema is there. Pupil bilaterally equal, sluggishly reactive in right eye, but normal in sluggishly reactive in left eye, normal in the right eye. Rest other CNS examination is normal. So this is the fundus photography. Here the optic disc edema is there. MRI orbit was done, which was suggestive of the T2 hyperintensity in the both optic nerve, with involving the all segment of the optic nerve with perineural enhancement is there. So laboratory investigation is also the normal. CSF examination is normal. Again, we have sent the anti-MOG antibody, which was positive. NMO is negative. So diagnosis is recurrent optic neuritis due to MOGAD. And treatment is we have given the IVMPS for 5 days and followed by the prednisone and azathioprine. And she has no relapses after this on the azathioprine. So why we have discussed the two cases. So both has the MOGAD. So what is the MOGAD? So myelin oligodendroglycoside glycoprotein is a type 1 integral membrane protein localized over the external surface of the oligodendroglyocytes and detected by on the cell-based assay in serum which detect the MOG IgG antibody. So there is no marked sex preponderance. Male and female are both equally affected. Onset in both age group, that as well as in children as well as the adult. And 20 to 40% cases are the post-infectious cases, and rarely the post-vaccinations cases are there. So which are the clinical phenotypes of the MOGAD? So 6 core clinical demyelinating events are there that are associated with MOGAD. So most common first 3 is the optic neuritis, that the commonest one, and particularly the adult. Second is the myelitis. Third is the edema, that may be associated with optic neuritis in children. Other less common are the cerebral cortical encephalitis, brainstem and cerebellar demyelinating attacks, cerebral monofocal and polyfocal CNS deficit. Other rare are the tumefactive cranial neuropathy and sometimes the leukodystrophy-like presentation. So first is the MOG plus optic neuritis. So case 2 we have discussed is patient is the first time optic neuritis. At that time most probably she has been given the steroid. Otherwise if steroid has not been given, but sometimes spontaneously MOGAD can be the improved. But recurrent nature of the optic neuritis in cases of the MOGAD is quite common. So patient presented with within 6 months with recurrence and require the immunosuppression therapy. So optic neuritis most likely presented as visual acuity loss, color vision impaired, RAPD present. But most particular features in case of the MOG associated optic neuritis is the optic disc edema on fundoscopy. And bilateral optic neuritis that will be common at the onset. Relapses often occur but unilaterally and sometimes may associated with the myelitis or edema. But important point is recovery is often rapid as compared to the neuromyelitis optica. So neuromyelitis optica, if patient presented with optic neuritis, we generally prefer the plasmapheresis plus steroid because residual neurological deficit in case of the NMO is quite common and that will also the debilitating for the patients. While in MOG associated optic neuritis, the recovery is quite good. Relapses are common. That will be the manageable. So important point in 2 cases is the differentiate the MOGAD from the other demyelinating attacks like other diseases, the neuromyelitis optica, multiple sclerosis, or other the seronegative sometimes demyelination, or the sarcoidosis, or the paraneoplastic etiology, or sometimes the multiple systemic disorder, connective tissue disorder that presented with demyelination sometimes like SLE, Sjogren or Behcet. So these are the MRI findings. Like first is the fundoscopy finding that will suggest you of optic disc edema. This is the optic nerve involvement is quite characteristic in case of the MOGAD. Particularly it involves the all segment of the optic nerve and that is the anterior part, but not involving the optic tract and optic chiasma. With perineural enhancement is also there. And while on the visual field examination, particularly the central field is also the more affected. While in NMO, central plus peripheral field are the more affected. So this is the common optic nerve involvement in common demyelinating disease. So first is the multiple sclerosis in which the focal segment of the optic nerve is involved. NMO, that is aquaporin antibody positive, which involve the longitudinally extensive optic nerve plus optic chiasma or optic tract. While MOG is involving the extensive optic nerve, optic disc swelling and optic perineuritis that will presented as the perineural enhancement. So all 3 is the different treatment, all 3 is the different prognosis. MS having the lifelong treatment, NMO has having the different treatment part as compared to the MS, but require the prolong the monitoring. While MOG is the easily recovered, and sometimes the nearer complete recovery is there. So MOG plus EDEM is another phenotype. So generally the presented with headache, vomiting, seizures, features of encephalopathy and multiple focal involvement in form of weakness, sensory involvement, or sometimes even the altered sensorium. And most commonly presented in children, sometimes associated with optic neuritis or the myelitis. Post-infectious episodes are quite common in case of MOG-EDEM, like in our case, case 1, that will presented after the post-infection, some post-viral infection, patient has developed the MOG plus EDEM. And complete or near complete clinical and MRI resolution is there in case of the MOG-EDEM, while NMO-associated EDEM or the other EDEM like connective tissue disorders, sometimes the prognosis is not quite good as compared to the MOG-EDEM. Another is relapsing attack can be occur after EDEM, but that can be controllable and sometimes cause the multiphasic EDEM. So these are the common features. So generally MOG-EDEM is presented as ill-defined white matter involvement or along with the deep gray matter involvement, like in case of the thalamus involvement. So multiple involvements are there. White matter is quite involved along with the deep gray matter. Third common presentation is MOG plus transverse myelitis. So myelopathy generally presented whenever we suspect the myelopathy, when the patient has the sensory, motor as well as the autonomic dysfunction. And associated transverse myelitis can be present along with optic neuritis. Good motor recovery is there, and rarely the involving the permanent bowel bladder involvement, and recurrent transverse myelitis are rare. Generally recurrence in MOG generally presented as the more commonly as the optic neuritis as compared to the myelitis. And particular pattern in the transverse myelitis is like that involves the spinal cord is centrally located. H-shaped sign is there that involves the central gray matter. Contrast enhancement is there. Even sometimes the clinically silent spinal cord lesion can be seen in the brain as well as the optic neuritis symptoms. Conus involvement is the quite characteristic. So whenever the MRI patient presented with myelopathy, having the H sign, conus involvement, and particularly the post-infectious, so most likely the MOG will presented with this type of the presentation. So this the features can present as the longitudinally extensive transverse myelitis that involves the more than 3 vertebra. This is the non-LETM pattern. This is the mixed pattern. This is the H sign, and this is the conus involvement. The less common involvement is the cerebral cortical encephalitis that presented with seizures, and encephalopathy and seizures are the most common. CSF suggestive of pyocytosis, and MRI will show the like classical encephalite cortical involvement is there, and IVMP is effective. So this is the image. So sometimes quite confusing with the acute viral encephalitis. So only the cortical involvement is there. The gyri edema is there, and also the contrast enhancement is also there. But it's sometimes difficult to differentiate from the viral encephalitis. Other rare phenotypes are the brainstem and cerebellar demyelinating attack. So MOG generally involves the middle cerebellar peduncle involvement and the lateral side of the midbrain, while NMO will involve the commonly the dorsal medulla part. So this was the main differentiating features between the two demyelinating diseases. So which are the supporting radiological features that will give you the clue for the MOGED? So first in optic nerve, so longitudinally extensive optic nerve, an anterior part, node without optic tract and optic chiasma. In spinal cord, conus and H sign. Brain, the multiple ill-defined T2 hyperintense lesion as in the deep gray matter involvement, and cerebellar peduncle and cortical lesions sometimes. So these are the supporting features that will give you the clue for the diagnosis of MOGED. So how will you diagnose MOGED? So according to international consensus criteria, and 2023, one core clinical feature is required that includes the optic neuritis, myelitis, edema, or cerebral monofocal polyfocal deficit with brainstem or cortical encephalopathy in combination with positive serum MOG antibody level. So that will the titer is more than 1 gem 100, or if the titer is not available or the weak positive is there, then it will require the one supporting MRI features that I have already described. And other features is exclusion of the other diagnosis. So these are the core clinical ethics features and supporting features. So treatment, generally relapse, if we see the 10 years of follow-up of the patients, generally 50% patient has the relapses, and particularly the adults have more relapses than children. More relapsing disorder is the optic neuritis as compared to the edema and myelitis. Recovery in adults is generally 70 to 80%, and children is up to the 90%. So treatment in MOGAD is not just given by the guidelines like FDA approved, as in the MS or the neuromyelitis optica, but these are the treatment was given by the after the 10 years of the follow-up studies. So in acute presentation of MOGAD, generally patient require the IVMPS, methylprednisolone. If patient has severe symptoms or then rapidly progressive illness, then the plasmapheresis is also effective along with IVMPS. In cases of like LETM, bilateral optic neuritis, or optic neuritis with myelitis or edema. Oral prednisolone, if given more than 12.5 milligram per day for at least 3 months, so that will give you the 88% reduction in the relapse risk. Other immunosuppression that can give is the azathioprine, mycophenolate, and rituximab. In cases of the refractory or cases like if the patient is recurrent attacks on the azathioprine or mycophenolate, the IVIG and tocilizumab are the having good efficacy as compared to the rituximab. So these are the MOGAD treatment. So last is the clues for the immune mediated myelopathy. So how will you suspect the immune mediated myelopathy? So first of all, when will you suspect the myelopathy? If the patient presented, which are the features that will give you the clue maybe the patient has the myelopathy. So if patient is sensory plus motor plus autonomic dysfunction, so these are the three combinations that will give you the probable diagnosis of myelopathy that will clinically. So in case of the immune mediated myelopathy, history is important, like time course of the disease. Generally, the demyelinating disease presented acutely, severe in intensity. So generally, the nadir of the disease will reach within the 21 days, but more than the 4 hours after. If within the 4 hours is there, the vascular myelopathy will be the suspected. Sometimes the subacute to chronic cases are there, like in neurosarcoidosis, paraneoplastic, multiple sclerosis, that will presented as the chronic myelopathies. Other history part is the trigger, post-infectious, post-vaccination, and co-occurring autoimmunity like SLE, Behçet, Sjogren, sarcoidosis. In case of paraneoplastic myelopathy, the history of malignancy that include the lung, breast, lymphoma, gynecological, and family history, particularly in the multiple sclerosis. So clinical features, myelitis, or particularly the isolated myelitis is there, or myelitis with cranial nerve involvement is there, or myelitis with other brain lesion. So that will give you the clue that the patient is most likely the immune mediated myelopathy, like NMO, MOG, all have the brain as well as the optic nerve involvements. CSF, so generally immune mediated myelopathy have CSF cells more than 100%. And other parameters will do like is the CSF cytology in case of the paraneoplastic. MRI is early involvement, generally the hyperintensity along with the contrast enhancement is there. Site of the lesion, particularly like conus involvement, cervicomedullary junction in case of NMO, dorsal pile base lesion in case of the sarcoidosis, multiple non-continuous lesion in case of the paraneoplastic myelopathy. These are the immune mediated myelopathy's clue. And length of the lesion, LETM, that particularly common in NMO, MOG, non-LETM lesions particularly common in MS, and mixed pattern that can be seen in the NMO as well as the MOG. So these are the I'm completing.